Okay. Do you hear me? You're supposed to have more people joining, but I'm going to start because I want to start early. Uh, so did you receive all the three PowerPoint and the rest so far? Okay, because I did send it to you, so I will resend it to you later. Oh, oh yeah. Okay, I will resend it to you then. Okay, let's start. So today we're going to start at least for a couple of weeks about tumors. Uh, why I want to start with tumors, because I noticed that a lot of students do have issues with tumors, and since in systemic tumors are everywhere, and in USMLE tumors are high yield, especially in molecular biology of it. So we're going to start with tumors, and then we might do maybe in 2 weeks from now kind of basic pathology review about necrosis and stuff and inflammation. But night time will be we're going to do a tumor for the next 2 weeks, and then after that we start hematology. Uh, so as the plan, we're going to start to do generality about tumors. That is for today, and then we're going to do clinical presentation for tumors, and then we go for each of the tumors, the benign and malignant tumors in by itself in detail. And you're going to notice, for those who were with me in class in pathology, these are almost not the same slide. I did do a lot of changes. These are the usual slide that I teach with, and there's a lot of more slide than usual and more information. So hopefully you're going to learn a lot from them. So why tumor are very important is simply because they are very frequent. Everybody is afraid of cancers, and tumors can come different shape, different ways. Some tumor will kill, some tumor will not kill, and but many tumor will make you miserable, and other will not make you that miserable. And remember that sometimes there's some lesions, like in here, look like a tumor, it smell like a tumor, but it's not a tumor. It's just a hyperplasia. And as others are can be preventable, and for example here, cervical cancer, which is pretty much invasive, but now with immunization, which you need to know, the treatment, the it seems that within the last 5 years, cervical cancer is more preventive by this immunization. And immunization is given usually a young girl, 14 years old, and to prevent them against HPV given cancer, which we're going to talk later on. At the end of tumor, we're going to go over all the treatments, generality of the treatment, and then we're going to do the specific by organ, but all the chemotherapy that there is up there. I remember for you, Samali, chemotherapy are very high yield. So you need to know what are the different type of chemotherapy and indication and side effects, specifically side effect of them. So sometimes, well, you can deform yourself. It looks like a tumor, smell like a tumor, but it's not a tumor. And sometimes tumors, like in this situation of fibromatosis, can be pretty much destructive. And actually, in this guy, you ask yourself, how can he eat? How can he see? How can he breathe? Uh, because of the all the complications that he might have. Most of these neurofibromatosis do not have much of treatment besides cosmetic treatment and and even with that, you don't have any solution really. So if it looked like bad, it might be bad. That is at least most of the lesion that you want to find, but sometimes they look like bad, but they're not bad whatsoever. And some, if it's malignant, sometimes malignant do react like benign. But progression of all these tumor vary depending on the type of tumors. Most of the time, if it looks good, you might be good. You might behave good. But sometimes you have surprises. This is why be careful in medicine. What it seems is not usually what can be. It can be very good, look like very good, and then complications occur very fast with these type of tumors. So, as definitions, what does it mean neoplasia overall? It means tumors, but it means new growth. Something that just growing, and doesn't stop growing. Um, and tumor or tumefaction means increase in size. You can use this term as tumefaction, for example, in inflammation. All the edema and inflammation are called tumefaction, so tumors. Remember the typical sign of inflammation as regular tumors, etc. Oncology is the specialization of malignancy usually. So you have many branches in oncology. You can have surgical oncologists versus medical oncologists, and everything between. Actually, this is a good specialty for women that want to stay home at night. Uh, so, contrary from surgical oncology, it does not much of lawsuit because, well, usually they operate. Well, they can operate in the beginning of tumors, but they can operate in late stages where there's no chances of survival. Um, so, how the tumor develop? We're going to have just one chapter about the progression of tumors and how the tumor are going to happen. Remember just one thing: anytime you have an irritation that is constant, becoming chronic irritation, anytime you have inflammation that become chronic, um, every time those all these creating lesions and all these region because it's healing, and destruction are risk of big cancer. So remember, but the basic of all cancer that will start is about the change of DNA, is about the mutation. And the mutation, this is what give you a new type of cell that uh, get out of control. So remember that tumor are cells that just increase number, and then you're going to have different type if benign or malignant. So this is why it's about a problem within the cell growth and how it's going to react. So the growth is going to be a constant growth. So, but so again, there is if you one of example, if you take a normal cells and put it in a petri dish and let it grow, it's going to grow nonstop until it finds the wall of the petri dish. Then it will stop. Contrary from cancer cell, even if it found the wall, it keep growing and growing and growing and growing. So there's a kind of invasion. And remember that basically all the cells should have an apoptosis. Here there's an apoptosis, yes, but its delay is not controlled whatsoever. Meaning that if a cell is supposed to live 20 days, in this situation, it's going to live 60 days. Uh, and the behavior is going to change. What does it mean by behavior? It means the destruction that you're going to have. And that is super important for the clinical presentation of your tumors, which you want to discuss in the clinical part of it. Uh, the changes must not be lethal, and it goes from daughter to daughter, meaning that you're going to have a monoclonal division of your tumors. So from one cell, you're going to have two cells. You're going to have four cells, six cells, and you keep going and going and going. And remember that since there's a problem with the DNA itself, so it means that you're going to have problem with a gene. So usually it's one gene or more than one genes that are involved in the changes. This is what we will talk about later on. The genes are going to be oncogenes, are going to be suppressor genes, and meaning that the suppressor genes cannot act, and the genes that's supposed to be inhibited will not be inhibited, and this is what where everything is going to start. So it's a sequence of event that will lead you to those issues. So the causes, once again, can be intrinsic, extrinsic, so it depends on the really on the situation. So now the question that you always ask yourself is, what is the difference between a normal cells versus neoplasmic cells? And once again, that is about growth factor, is about growth. So if you have a problem with growth, one thing that is going to happen is the cell will just grow, grow, grow. This is all the tumors. You see them very massive, very big, especially the benign tumors. Sometimes it can be super, super big. It's about cell death, which is apoptosis. Could you control the number of cells, or you cannot control the number of cells? If you can control it, that is normal, and that is what happens usually in normal cells. But in cancer cells, benign cells, usually the cell control, especially cancer cells, cannot be controlled whatsoever. And everything else, especially the growth factors controller, uh, you're going to see that there's many type of growth factor which simulate. Normally, every cells do have growth factor to grow, but the abnormality here is that those growth factor become abnormal. So it means that only they are not inhibited; they're only stimulated, and this is one of the reasons that the cells start to grow very fast, becoming adult very fast, and then dividing. And then you're going to have what you call the interaction between the cells. Normally, all the cells, beside the free cells like leukocytes and red cells, normally all the cells are interacting between each other. You have an adhesion between those cells. You have an adhesion with connective tissue. And it means this adhesion is stable, otherwise the tissue will be destroyed. In the cancer cell, for example, especially in cancer cell, you're not going to have this adhesion between the cells. And the lack of adhesion, what does it mean? It means that the cell become floating. And that is one of the reasons that you can have metastasis. Because the cells being free, it can go to the bloodstream without any problem. And remember, when it goes to the bloodstream, it's still dividing itself until it reach one of the area of metastasis. Cell stroma, it's the connective tissue, which is going to change actually as a connective tissue, because you're going to see that in tumors, you're going to have angiogenesis with the new proliferation of blood vessels that is going to lead to what you call dysplasia. We'll see this later on, which is the changes of the connective tissue that change for the tumor to grow really. So the other problem would be the growth control, which is once again increase of cell proliferation. You're going to have more and more cells that are going to be dividing. This is why one of the keywords when you look at your slides or histopathology slides is going to be about mitotic figures. More you see mitotic figures, more this is an aggressive tumors, more it's a tumor. You have it. You determine it as a tumors. We're going to see what create those division of the cell later on. So if there's a division, obviously the life of the cells is going to change completely, and that means that you're going to have decrease of apoptosis, meaning that like I said, if a cell's supposed to live 20 days, you're going to see it living 120 days, and that is not normal. All the metabolism of the cells are going to change. What does it mean? It means that all the cancer cells are going to take all the energy that is surrounding it. And this is one of the reasons that one of the clinical sign of anyone that has a malignancy is going to loss of weight in a short period of time, because remember, in this situation, you're going to have a negative azote balance metabolism, and meaning that it's going to use everything. So it's going to use the protein and the energy of all what is surrounding it. And the main thing is going to be angiogenesis. Angiogenesis, why is super important, is because it's going to attract, need to have energy. So you need to have energy right now, not later on, but right now. And the energy that is, and oxygenation that come from the angiogenesis. Actually, one of the one significance in clinical presentation of a tumor for angiogenesis will be bleeding. All the malignant tumor, even benign tumor, can bleed, and that is one of the signs. The other sign is you can clinically you can emboli all these blood vessels and starve the cancer cells or the tumor that will decrease in size. But it can be dangerous as well because that will create a necrosis, and those necrosis can lead to some of the issues. But keep in mind that one of the clinically or by angiography, or even when you look at the tissue by histology, if you see a lot of blood vessels surrounding tissue, it means two things. Either it's a tumor or it's an inflammation. These are the two reasons. The only difference is with the inflammation, you're going to have inflammatory cells. In cancer, you're going to have the inflammatory cells, but you're going to have also mitotic figure, division of the cells that you don't find in the inflammation. And also the inflammation, it depends if it's a chronic or acute inflammation. Remember, in acute inflammation, this is where you're going to have the most of the blood vessels. And that is a criteria for your inflammation. While you have it during inflammation, because you need to have all the material to heal. So the other issue with the growth control is either increasing or decreasing the growth factor. And remember, the growth factor that it will stimulate is about receptors. So if you have receptors that are abnormal or lack or increase of number of receptors, that will increase or decrease the growth factor action. And remember that number one thing about cancers or tumors is about growth factor. And this is why there's several growth factors that we will talk about and that are important for the board as well, that you need to know as normal growth factor for normal tissue that will act in inflammation or during tumors. So this is why these growth factors need to be produced somewhere, and that is one of the important area of production. So if you decrease them in a tumor, then you save because the tumor is not going to grow whatsoever. That would be a good thing. So remember that you're going to have receptor of the growth factor, and you're going to have the growth factor that are going to act. This growth factor, what they do, as the name says, growth factor. So it means making the cell growing. So the cell that are baby need to become an adult, and as any adult, the big thing is reproduction. So you're going to have a stimulation of the nuclei by what you call activation of the transcription. That is going to lead to the division of your tissue or your cells. And what create the stimulation or activation transcription will be a signal transduction. And this is stimulated by the growth factor itself. So without any of these elements, the cell cannot divide. And this is why when you look at the chemotherapy itself, the goal of your chemotherapy is to act in one of these four regions or completely destroying the cell. So you have many type of chemotherapy, and this is why you have all these side effects of lysis, specifically, for example, when you have leukemias and you use chemotherapy, gout will be one of the complications. So you need to give a preventive gout treatment for these patients. And also the problem with the chemotherapy is the chemotherapy will not kill only the malignant tumors, but it's going to kill also the good cells, and that is another. It's an issue. So, like I was saying earlier, normally the cell interact between each other, and that you need to know that from histology. So, for example, you're going to have the desmosome that connect the cell between each other. You're going to have the gap junction. You're going to have the tight junction, and you're going to have the hemidesmosome that connects the cells towards the basal membrane. And here as well, we're going to have receptor in all the area of the cells. But in case of loss of case of tumor or malignancy, you're going to lose those desmosomes and those hemidesmosome and your disconnections. And by losing it, it means that the cell will be free. If the cell be free, they have space. And this is why in tumoral cells, you can see that the cells start to increase in size, and specifically the nuclei becoming bigger and bigger and bigger. And this is what tumors, as the name take is a tumefaction, increase in size or a mass. So it depends on what mass. But remember, if we talk about mass, if it's a benign mass, usually it's mobile. Usually it's non. It can be painful, but mobile is the keyword. If it's a fixed mass, non-painful, that is the danger. Because it means mostly cancerization. So this is the cell interaction that is going to happen, and then interaction with the stroma. Like I said earlier, the main thing is the basal membrane. Why the basal membrane is an important part is because this is the part of invasion. Once the cell starts to divide itself and it goes beyond the basal membrane, it means it starts to invade completely the stroma, and it means you start to have ulceration, you can start to have bleeding, etc. And this is the beginning of actually the invasion of any metastasis. But remember that this is not the same for all the tumors. Benign tumors do not go above the basal membrane. And there's one cancer actually that do not go above the basal membrane but can be invading. And that is basal cell carcinoma of the skin, if you remember that. So the other important between is the differentiation. So the differentiation is a cell that become a cell that you recognize, meaning that if you look at the thyroid tissue, you recognize the thyroid tissue. That is a maturation. This is the differentiation. But this started from an embryology and then stimulation to grow to a normal cells that will have a very specific function. Now, in case of tumor, that can be an issue because some of the cells that we're going to call this type of tumors anaplastic, they look like actually embryological type of cells. So they go back to the original cells. And knowing also the umbilical origin, it means that there's some tumors that are the same origin. So it means you can have these tumors popping up here and there because of the same origin. For example, the epidome tissue, which is going to give you production of hormones, and for example, serotonin can be produced by it. And also remember that anything that looks like baby, a blast, usually a bad prognosis because these are very aggressive type of tumors, and we're going to see some of them later on. But the embryogenesis is very important for to understand different type of tumor. But keep in mind that as a baby cells, you need to have the growth factor that is going to make it growing fast to an adult to have a certain function. So this is why sometimes there's some tumors where they lose completely their function. So one of the things that is important is about the parenchyma proliferation and the stroma proliferation. Both of them will give you different type of tissue. So remember, when you look at slide and when you look at lesion, usually I always say think about cancer to prove otherwise, because sometimes we can miss it. But the first question usually you ask yourself, is it benign? Is it malignant? And to remember, you're going to have four type of origin of the cancer itself. And actually, one of the things is to know how to name those type of tumors. This is what you're going to see today. So you're going to have epithelial, you're going to have connective tissue, you're going to have lymphoid and hematopoietic, or you're going to have the germ cells. Germ cells usually give you embryological type of tumors, and this is what you call the blastomas. Every time you're going to hear, you're going to have the end of it will be blastoma. So we're going to see the different type and how you name all of them. So in here, so like I said, when you look at mass, two questions that you ask yourself: is it benign or is it malignant? So now, if it's, for example, if it's a benign, usually the name or how you're going to name it is you're going to finish by oma. Adenoma, gland, tumor; angioma, blood vessel tumors; rhabdomyoma, skeletal muscle tumors; or it can be carcinomas, and then in this case situation you're going to end up with carcinoma when you name it. So know your nomination, because that can be also a question, and also you know where it come from. So for example, squamous cell carcinoma, stratified type of epithelium; adenocarcinoma, glandular carcinoma; or it can be sarcomas. And sarcomas, remember, are very, very common type of tumors. For example, angiosarcoma, blood vessel; rhabdomyosarcoma, which is a skeletal muscle tumors. Now, there is some tumors, there's some naming that are a bit confusing, because they look like benign as how you given the name, but by now you're advanced enough to know that they are not that benign. For example, lymphoma, mesothelioma, melanoma, oma, seminoma, all these are pretty much aggressive type of malignancy. There are some that are not tumor whatsoever, and the name look like a tumor. For example, choristoma is a tissue that is not supposed to be there. It's a normal tissue, but wrong location. One of the example here is endometriosis. Hamartomas as well is a tissue that look like completely malignant when you look at the microscope, but it's totally normal. It's a tissue that is completely disorganized. There's no, you don't recognize it in any of the tissue that is known. It look like a cartilage, it look like a bone, but do not mix it up with the teratomas, which can look like teratomas. But for hamartoma, keep in mind or remember popcorn looking on x-rays, especially if you have it in the breast or you have it in the lung. But the typical will be popcorn looking. I'm going to see the association between hamartomas and many malignancies. And one of them, remember, it's Butt-Jaeger, the tumor or polyps, which is polyposis, family of polyposis plus hamartomas. The polyposis are hamartomas, and brownish discoloration around the mouth and stuff. And that is one of the very common uh, ask in USMLE. Some of them, the name, you don't know where it come from: nevus, leukemia, hidatiform, but hidatiform that is benign. This is choriocarcinomas, which is mostly the malignant one. So this is how you name your tumor overall. So if it's if you have parenchymas, which are part of, remember that the mesenchymal origin, it means baby origin. Anytime you hear the mesenchymal, meaning connective. And for example, fibroma, that is benign, see oma; fibrosarcoma; lipoma, liposarcoma; chondroma, chondrosarcoma. So you add always a sarcoma at the end for the connective tissue itself. So sarcoma. Obviously, the beginning tell you the origin of it. Fibroma, mostly fibroblast; lipoma, fat; chondroma, cartilage; and osteoma, bones. Now, if it's endothelial cell, blood vessels, you have three type, remember, and depending on the size as well, but you have hemangiomas, and the cancer of it is angiosarcomas. But sometimes you have the term angiomas as can be used. Lymphangioma, lymphosarcoma, meningioma, which is the malignant, which is rare, is the invasive meningioma. But this is mostly the meninges benign tumors. Now, depending on the type of epithelium, if it's one layer or multiple layer, if it's multiple layer stratified squamous, no matter in this situation, if it's keratinized or not keratinized, usually you call it squamous cell carcinoma as the malignancy. If it's benign in this situation, it's papilloma. And keep in mind, every time you hear the term papilloma, it means finger looking like. So you have projection of this type of tumor like fingers. So you cannot miss them. So the squamous and the basal, remember that the basal cell carcinoma are a tumor, once again, that do not cross the basal membrane. And it is going to invade, but doesn't cross the basal membrane. So then you have the glands, everything that is gland is adenoma or papilloma, like finger again, or can be cystic. So you have mixed type of tumor, and this is when this situation you call them cystadenoma. And obviously you use the carcinoma terminology in the end. There's some tumor, for example, renal cell carcinoma. You can call them also. They can have other names like clear cell carcinoma. And clear cell carcinoma, it can be in many tissue, but the renal can is the first one that you need to think about it, etc. Sometimes hepatocarcinoma, for example, you use the term hepatoma for it, or you can use hepatocarcinoma. But if you see hepatoma, it means hepatocarcinomas, etc. So I think by now you should know your nomenclature. So the for the blood, usually you don't have benign; you have only malignants, leukemias or lymphomas, and as you know, there's many type of leukemia, many type of lymphoma, which we're going to discuss. Specifically, we're going to discuss this in hematology. And remember, the leukemia and lymphoma have super high yield, so these are you need to pay very much attention to those. And these are type of tumors that they will give you smears for interpretation. For the muscle myoma or rhabdomyoma, so skeletal versus smooth, and obviously you end up with sarcoma at the end for the lecture. So now remember that sometimes you have some glands that are mixed type of glands, meaning you're going to have two type of secretion. For example, and the typical one is going to be the salivary gland. And if you have double mixed type of gland, this is what you call pleomorphic type of tissue, pleomorphic adenoma. So if you say pleomorphic, you know that there's two tissue that do have the same function but produce differently. Some obviously do have specific name. For example, Wilms tumor, which is a big tumor that you see in kids and high yield, um, and also you need to know the gene for it and the association that goes with Wilms tumor. I'm going to discuss this in kidneys tumors. Otherwise, you're going to have the mature teratomas. And the thing is, if it's mature teratoma, usually when you think of mature, you might think of a malignancy. But here, mature teratoma are benign. The other name, especially for the ovary, you can call it dermoid cyst. And this is the actually a type of tumor. As you know, there is all the layers of the embryology in it. And this is why you're going to see mixture of tissue within it, like the teeth, the hair, the skin, cartilage, etc. As when you hear the immature teratoma, this is a very much aggressive type of malignancy. You need to be very careful because if diagnosis is not made, then this patient are going to die soon. And this is what we call, actually, for this type of tumor, totipotential cells. Why? Is because totipotential cells are embryological stem cells that are going to give you different type of tissue. Remember the three layer for embryology. So I give you here some of the example of location of some of the carcinomas. For example, squamous cell carcinoma, you can find oral pharynx, mid-esophagus, larynx, lung, cervix, skin. Remember, skin, you're going to have the keratin associated with it. But when you look at them in the microscope, they're all going to have the same structure, the same looking type of lesions within them. But know the location, because sometimes they give you just the location, they will not give you a type. And you need to guess by location what type of tissue there is. So this is why I always suggest students before studying the tumors to review their histology, because histology become very much handy in this chapter. We did do some histology review two weeks ago, but you need to go over it again and again. So adenocarcinoma, glandular. So the glands everywhere, but remember, so the location might be different. But there's one transitional, and that is mostly the bladder or the pelvis, renal pelvis, that has transitional. And remember, for the transitional epithelium, you're going to have the dome cells on top of this type of epithelium, and the dome cells are half curved type of cells on top of that typical epithelium. And remember that all these cancer might have association with other condition, which we're going to talk about in the paraneoplastic syndrome. So the acute tumor, like I was saying, these are a very particular type of tumor, because these are tumor uh, that give you carcinoid type of tumors. And carcinoid type of tumors, or just think that acute tumors usually are paraneoplastic in general. And like carcinoid tumor are hell, because you need to find the tumor first. And these are tumors that are producive type of tumors. And they have the same embryological origin, which is the acute system. And what does it mean? Acute is mostly the amine precursor update and decarboxylation. For example, serotonin is one of these amine precursor. Most of them as well are going to be producing hormones. And this is why, for example, here you see small cell carcinoma or cell carcinoma. I remember those type of tumor produce, which are pretty much high yield, produce ACTH and produce ADH. And like we saw this morning, these can give you Cushing syndrome, or can give you SADH. Cancer in the location also can be very particular for this type of tumors. Um, One thing that you need to, two things that you need to remember about this type of tumor: the stain, S100 antigen positive, that can be asked, and the embryological origin, neural ectoderm. This is why you have the neuroblastoma. See, neuroblastoma is most embryological type of tumor, pretty much aggressive. Melanomas come also from the ectoderm crest. So these are tumors that come from the mesenchymal tissue. Once again, you need to look at them as how they look like, and what is the different type. So for the mesenchymal, you're going to have the embryonal rhabdomyosarcoma. That is the most common sarcoma in kids. We're going to see some of the what is most common later on, but this is just an introduction to the different type. I need to replace the H here. Uh, the myelin fibrous histiocytoma, which is the most common sarcoma in adult, and for example, liposarcoma is one of them. And remember that all these type of tumor usually are pretty much vascular, a lot of necrosis, like any many of the malignancy. And one thing that are important, they are very large type of tumors. And the metastases are using blood for metastasis. So the pleomorphic, as the mixed type of tumors, This think about salivary gland right away, like I said earlier, that are the most common one. So the malignant lymphoma, which is a bit particular type of that touch lymphatic, in here there's many classification of it, but it depends if it's Hodgkin's or non-Hodgkin's lymphomas, and then you go with classification. Teratoma, like I said earlier, it comes from different layer, and need to look at them. Is it mature? Is it immature? Type of tumor, because sometimes for the teratoma, you do an X-ray, and by accident you're going to find teeth within the ovaries, and you ask, actually, have a case like this, and the first question that you ask is, did you swallow your teeth? And the answer is no, not at all. And when you open up, you're going to find teeth and other. I will show you some picture later on. The trophoblastic one, which come from the placenta itself, you're going to have, obviously, here is the best timing to review your placenta tissue. You're going to have two parts, the syncytial and the trophoblast. And here, usually, this is what you call gestational type of tumors, which are the most common usually. Uh, the location, the most common location, for example, the yolk sac tumors of the testes is one of them. Now, keep in mind, and this is why I put it in red, because this can be a question for you, Samali. The sensitive trophoblasts are going to secrete the 13 HCG. I remember, just HCG is, you know that there's a pregnancy going on, but in the situation, most a tumor, not a pregnancy. So the germ cell, think about the testes, think about the ovaries, but in the testes, this is where you're going to have the teratomas. You can have teratomas as well in ovaries, but in ovaries, you're going to call them desmoid cysts. Or you're going to have the most common, the most frequent, most common tumor of the testes will be seminomas. For the lymphoid, obviously, they depend. Lymphomas, BOT or Hodgkin's, and bone marrow. Usually, you talk about leukemias, depending acute, chronic, and that is going to depend on age of the patient. Remember, for the leukemia, most of the chronic are for adult, and most of the acute are for the young. But obviously, here as well, there's a differentiation sometimes, because you can have acute and they are not kids really. But for the kids, the acute lymphoblastic leukemia are the most common. And for the adult, is going to be the chronic lymphocytic leukemia that is the most common. So remember, for the USMLE, you need to know what is the most common, absolutely. Most common, most common, most common, and then you go to the least common type. So the blastomas, every time you hear blastoma, it means immature, it means baby, it means aggressive. And most of the kids, most of the newborn that might have a tumor are going to be blastomas. And it means that death will happen very fast. But it's not always the case. For example, retinoblastoma, yes, it can be very aggressive, but this is a tumor that can affect both eyes. And obviously, everybody talk about this tumor ceremony just for the red, for the genes of it. So the other one, neuroblastoma, brain tumors that can be aggressive, or hepatoblastoma that are very rare, but still it's fetal hepatocyte that are involved with it. So these are the hyponym, meaning the name that are renowned, and these are the name for them. This is just for your own information. It's not that important. But just know that they are eponym because you have names: Hodgkins, Hewings, Wilms, Kaposi, Burkitt's, etc. So dysplasia, what does it mean? It means it's the connective tissue that surrounds the tumor that is going to change. This change is going to lead to attraction of blood vessels, and a lot of blood vessels, and a lot of thickening of your connective tissue. And this is a very specific type of connective tissue. So you're going to have fibroblasts that are going to be activated, and this is what will give the tumor its hardness shape, a very very hard shape. So I put you here two example. For example, the serous breast carcinoma or the prostate carcinomas, which are tumors that are super super hard, and that is because of connective tissue and the collagen deposit all around that you see in here. This is breast, and you have the malignant tumor that are infiltrating. You start to see division of cells and all the dysplasia all around. So here, just to give you what are the usually the origin, embryological origin of these tumors. And remember that anything that is epithelial can come from ectoderm or endoderm. Everything that is connective tissue comes from mesoderm. So this is why you just put your embryological review in here. So what are the mesodermic type of cell? Again, cardiac muscle, you have the skeletal muscle, you have the tubules of the kidney, you have the red cells, you have the smooth muscle. Anything that is ectodermic, then you start to think about skin. You start to think mostly epidermis of the skin. You can think about the neurons, and you can think about any pigmental type of cells within the skin. Endoderm, lung, thyroid, pancreatic cells, etc. So we're going to review each of the systemic later on. We're going to look at its embryological origin, and then we go move from there. So the cancer by incidence, we're going to talk about this a bit more later on, but keep in mind for now that the most common cancer in male is going to be prostate, then lung, then colon, and leukemia will be at the end. For female, the most common cancer are going to be breast, lung, and colon, and rectum. The most deadly in this situation is going to be the reverse. It's going to be lung for both male and female, then prostate and breast, and then colon and rectum. And the frequency of this type of cancer, you need to keep them in mind, especially the three most common tumor, because they're going to ask you can ask you a question about this. So the autosomal dominant, I'm going to skip this one because we're going to talk about it later on. But keep in mind that when you study a lot of these tumor, it's about knowing what is the gene, especially if it's genetic. What are, some of them you need to know the chromosomes, especially for leukemias. Then you need to know the chromosomes and what are the association. Meaning that can tell you someone, for example, that has a retinoblastoma, what is the other type of cancer that can have, and that is also sarcoma. That can give you leaf-Romani, for example, they can give you that there's a deficiency of P53, determining that this is a leaf-Romani syndrome. What are the other associations as a cancer? And remember that leaf-Romani, they can have all type of cancer at one time. They can have 6 type of cancer in the same time. So that this is opening hell to this patient. Obviously, knowing the mitoendocrine neoplasia 1 and 2, which we're going to discuss in endocrinology later on. This as well, which will be discussed, defective DNA repair syndrome. And those sometimes these type of syndrome are the association with work association or not. For example, xeroderma pigmentosum, which is autoimmune recessive, but sometimes when you're going to have irradiation, you can start to have this type of tumor, and the association, xeroderma, can be a cancer of the skin. So now, when you talk about benign versus malignant, you need to recognize it. You need to know what is the difference between them. Usually, it's very simple. So, remember that the benign tumors usually look like the tissue of origin. Usually, they are very regular. They have an adhesion between each other. You don't have much of mitotic figure. although the nuclei are going to be slightly increased in regard to the normal tissue, and that is the hint that there's a tumor there. Actually, the number of cells also are increased, but in the malignant, usually just by looking at the nuclei, give you a hint. The nuclei become very dark in color and increase in size. You're going to have more nuclei than you're going to have cytoplasm, and then you're going to have mitotic figure all over the place. The other difference, so that is a cellular difference. Now, you might have different sizes of cells as well. This is what you call pleomorphism in cancer cells. As the benign, usually the cells are almost the same size. Cancer, you can see big one, you can see small one, etc. So there's no uniformity within the number. As the chromatin goes, like I said, when you look at malignancy, you're going to have a very dark nuclei, mitotic figure that increase because the cell are always in division. And this is why sometimes even you can see the chromosome when you have mitotic figure. Everything is irregular. You're going to have once again the size of the nuclei are very big, as in the benign this will not be happening. And sometimes when you see the division of the cell, you can even recognize the stage of the division of the cells itself. So the nuclear membrane usually for malignancy are irregular. Benign, it looks like normal one. Besides that, is slightly increased in size, and usual malignancy is pretty much clumped together, very clumped. And remember, mitotic figure are one of your big elements in here. Keep in mind that a malignant tumor usually are anaerobe as metabolism. So they try not to use much of oxygen, although you have a lot of blood vessels that bring that much of nutrient and oxygen. They don't connect between each other. There is, like I said earlier, when you put a tumor, malignant tumor in a petri dish, it keep growing. Um Remember that because there's no adhesion within the cell, they can detach themselves very easily, and they can have transplantation. They can transport themselves and have transplantation in other organs. This is why when you operate on someone that has tumor, you need to be careful, as not if your glove are tear or not, because you can have a tumor spreading, and also between the organs, the malignant tumor are going to spread. One thing that you're going to notice is about the membrane. When you look at malignant tumor versus benign usually do have a capsule. Malignant do not have any capsule whatsoever. But be careful, there's some that do have that, those are exception to the rules, and some do not have exception to the rules, benign as well. But a capsule, it's the big difference between them. Actually, it's the capsule that make it easy to remove for benign tumor, as the malignant are that are, have just that just destroy and invade the tissue next to it. So it's very hard to remove it. You're going to make it bleeding. So when you look at the tumor overall, remember that once again the nuclei and you have hyperchromatism, so become very dark. It become like primitive, meaning that baby cells that are super large, and all the nucleus are become very big. And in here, you might find in some stain some marker for the chromosome itself or the oncogenes. Now, within the surface, you're going to have the markers for these cells, which you call the glycoprotein. Glycocalyx. Glycocalyx are actually markers for each cells. Each of the cells will have very specific type of glycocalyx, and this is why when you have too many of the cells, what's going to happen? You have too many of these receptors, and this is why in cancer the marker are going to increase. So remember, loss of contact between each other. If it's a leukemia, for example, or if it's another type of tissue that has to do with the blood group is going to be lost. The HLA of the plasma cell, for example, or the tissue are going to be lost, and you're going to have well, sometimes you're going to have virus antigens, but that is depend on the cause of your tumor itself. But remember that the metabolism are going to be increased in the cells so much, but that do not produce anything. That is, meaning that doesn't produce much energy. But keep in mind that there is some tumor like adenocarcinomas that are going to produce hormones. And producing hormones meaning that you're going to do, for example, the outside carcinoma producing ACTH, too much of it. Or you have pituitary tumors that will produce also hormones. So that is another story. So in here, what you notice is actually that look at the cells, and here you see division of the cell. The nuclei become too big, and here this is cell division that happen. Here the division happening. These are chromosomes that are migrating. This is a cell that multiply already. See 1, 2, 3, 4, 5, 6, 7, 8 type of cells. 2 cells divided already. And this is, if you compare it to normal tissue, normal cells with desmosomes, but you notice that the desmosomes here disappear. And this is stratified squamous epithelium. And here as well, it disappears completely. So the adhesion is gone. Most of the time, keep in mind, if you see cells that you have this sign, what you call the Mercedes sign or the cross sign, think about anaplastic tissue, anaplastic tumors. Anaplastic tumor where you have giant cells like this, very big cells. And usually anaplastic cells, you don't, they become embryological type of cells, and you don't recognize it from the original tissue. In this type of tissue as well, what you notice, first of all, is hemorrhage. It's an inflammation going on all over the place. And because you see all the inflammatory cells, you see all the red cells that are outside blood vessel. So we call that hemorrhage. You have here a plasma cell. And when you look at these cells, if you compare these cells, you're going to have different type of nuclei, and those are very dark. 2 dark nuclei here. See the hyperchromasia that's happening, and the cell are going to divide. And also you have in here a loss of connection between the cells. See, the cells start to become free, and the tissue is friable here as well. So those are typical signs of malignancy. But be careful. There's some steps sometimes like dysplasia, and severe dysplasia will look like the same way. In here is comparison between the benign versus the malignant tumors. So in adenoma, what you notice is you recognize that these are glands, but the nuclei is slightly darker, but you have a lot of cells. It looks like hyperplasia, or you have a lot of glands, more than it should be, but not as much. And you have blood vessels for each gland, meaning these, if it's they are exocrine type of endocrine type of glands because of blood vessel. If it was an organ, and here blood vessel might be something else. But here these are typical glandular, which we call adenoma, that don't go above the basal membrane. They're still within it, and usually they are not aggressive whatsoever. Now, if you look at adenocarcinoma already, if you compare them, too many glands, too many glands. The nuclei are mostly all dark. You have, see here, so dark. You have papillary looking, and it's all over the place. The glands are invading. So those are criteria for malignancy. So once again, here see the cross or the Mercedes sign. So, and giant cells. Actually, you see real giant cells, but these are very big cells, and those are anaplasia. Remember, anaplasia can be very aggressive type of tumor. They're the most aggressive one. So anytime classification you see anaplasia, you know that the one is the one that is going to destroy. This is the one that is going to go very fast. Although some say that they are radio sensitive, but most of the one that I saw are not radio sensitive whatsoever. Um, but they are very much aggressive type of cells. This is breast cancer showing some of the cells that are abnormal and they are big, big nuclei, dark nuclei. So remember that malignant neoplasm is the growth. You cannot control it whatsoever. If you can control the growth, it means it's mostly benign or normal. The cell spread all over the place, and then it spread at distance using the blood, using the lymphatic, using the direct contact. And remember that the invasion is going to be local invasion, then it's going to be local regional invasion, and then it's going to be a regional invasion, and then general type of invasion. So it means that you have metastasis all over the place. And whatever that go, then is going to destroy the tissue that is going to invade. So this is why when you compare them, the benign usually slow, very slowly. It takes years to grow. There's capsule. There's no capsule malignancy. Malignancy grow very fast. Once you get it, well, depends on cancer. Within 6 months, you're gone. For example, pancreatic cancer, melanomas, um, all these cancer spread or anything that's anaplastic. 6 months is after diagnosis is too late. Um, and remember, if you have a patient that lost have a lost weight, it's too late already. It means just look for metastasis. So it's infiltrating, and this one is pushing. That is one of the effect of benign. So we always say about malignancy destroying. Benign will not destroy, but what benign will can be dangerous for one reason. The benign tumor usually push all the tissue around. So imagine that you have a nerve. Imagine that you have vasculature. Imagine that you have a sensitive, for example, let's say the throat. What's going to happen? If the mass become very big, what's going to happen? All the vasculature is going to become smaller because it's going to be pushed. All the innervation are going to be you're going to have lesion within the innervation, and if it's in the throat, this patient might not they cannot breathe whatsoever. So that is one of the danger of the benign tumors. Otherwise, they don't create much of a problem unless they are productive. Meaning, for example, if you talk about an adenoma of the adrenal glands, they can produce hormones, and those hormones become abnormal. For example, Cushing disease, this is one of them. Pheochromocytoma, this is another one, which give you a lot of symptoms. So remember that benign tumor do not metastasize. They stay locally. There's just one exception to the rule, myxoma, which is not really metastasized just because the tumor is so friable that is going to spread, and the myxoma usually found in the heart. So when they become friable because of the blood flow, they're going to move from location. So we're going to see later on with the classification, but remember that benign tumor are well differentiated, meaning that if you look at it, you can recognize the tissue, and this is why we talked about the glands earlier. They look like the tissue, but keep in mind that malignant tumor as well can be well differentiated. And what is the importance of knowing that malignant tumor are well differentiated? It means that they're going to respond to treatment. They're going to respond to chemotherapy. They have good prognosis versus the poorly differentiated with bad prognosis. Now, obviously, the classification will be from well to anaplastic. So, well poorly differentiated, that is because they are aggressive. But keep in mind that it looks like the tissue origin. And actually, the importance of it as well is going to be that if they give you a slide and they put you in a blood vessel, they put you a tissue. Normally, in the blood vessel, you're not supposed to have any tissue whatsoever. But if you see a tissue in blood vessel, try to recognize what tissue is it, because that means it's a metastasis. It comes from somewhere else. Now, so the for the malignancy, once again, there's one big tumor that is known, that is a basal cell carcinoma, that do not invade, do not cross the basal membrane, or you're going to have the glioblastoma multiforme. I need to fix this problem. I don't know what happened. Um, but glioblastoma multiforme, which is an astrocytoma type 4 for adult, are very much aggressive. So by the time it's ready to give metastasis, well, the patient is dead already by engagement of the brain. So this is why it doesn't metastasize. But keep in mind as well that the most common tumor in the brain is metastasis. So overall, capsule benign, mostly usually is absent for malignancy. Growth, usually benign, expand itself. This is why it pushes the tissue. Malignancy, infiltrate, meaning destroy, meaning going over the basal membrane. And if it's above the basal membrane, you call that cancer in situ. Differentiation, usually well differentiated. Here it depends, but it can be well differentiated. Anaplasia doesn't exist for benign, but mostly for malignancy, meaning going back to umbilical type of cells. Rate, slow tumors. It take forever, very fast. Depending on tumor, once again, it can go between 6 months to 2 years. But also remember that the growth of malignancy in elderly, the malignancy grows slowly. As in kids, the malignancy grow very fast, and that is the differentiation as well. So, like I said, benign usually don't have any metastasis. Mostly is in the malignancy, but remember that benign. Usually, when you remove them, they don't come back unless you don't remove the whole thing. And usually, with the capsule that there is around it, you can remove it without any problem. But malignancy, most of the time you have actually recurrences. Either it's you the removal of the tumor was incomplete, so it come back, it grow back, or usually when you remove tumor because you don't know that you remove everything because you don't see the cell, maybe you left 2 or 3 cells there that they start to divide, and this is why they recur. But usually if you remove it completely, unless it's a new cancer, it will not come back whatsoever. And this is why, remember, before doing any surgery, you must, unless indicated, you must do a chemotherapy first, then surgery, and then radiotherapy. But also remember, for the USMLE, what you need to know is what are the tumors that are radiosensitive, what are the tumors that are chemotherapy sensitive, and what are the tumors that just respond just to surgery. And respond to surgery, that is depend on what stage of your tumor you're talking about. So the fate usually for benign, well, sometimes benign can kill you. But for malignancy as well, it depends to what stage you take it. And this is why everyone use $1 billion every year, every country to try to find prevention. And remember, the prevention will be your first answer for any question up there. Prevention, prevention, prevention first, and then the rest. So in here, just an example between two type of tumor. One that is leiomyoma, which is the tumor of the smooth muscle, which we call fibroid, and the leiomyosarcomas. So leiomyosarcomas are going to start to invade, going through the lumen, going through the peritoneum. The peritoneum would be around here, going through the rectum in the back, um, and invading the cul-de-sac. And this is how they start to bleed. Actually, you're going to have bleeding in the cul-de-sac. They can invade the ovary. So there's no demarcation, there's no capsule, there's no nothing. So these usually are poorly differentiated, and the typical presentation as well for this type of endometrial tumor, uh, uh, you can have an elderly that comes to you with menses. Be happy that she has menses, but can be also from the endometrium cancer. And remember, any elderly patient that come with vaginal bleeding, think about endometrial cancer and to prove otherwise, and then you go from there. And for the fibroid, in this situation, depend on the size of fibroid. It depends where you're going to have the fibroid, and also how many fibroid is there. Because fibroid is an example of a tumor that can make you bleed a lot and make you miserable as well. And sometimes you're going to do hysterectomy because of the fibroid itself, because of the bleeding that fibroid will give you. So, and also you can have miscarriage from it if it happens. Most of these leiomyomas usually are estrogen sensitive, but in here you can see because the endometrium is very well vascularized. Naturally, is very well vascularized. This is why when you do a hysterectomy, you are not afraid of clamping blood vessel because shunt are going to open up. So this is why the spreading of the tumor using the blood vessel are going to be very high, and this is why metastasis can be very frequently seen in this type of tumors. So remember once again, anaplasia, it's there's no differentiation because they are mostly umbilical, because mostly they are babies, and usually because they're undifferentiated, they can be very much aggressive type of tumor. So this is why you're going to have a very big division, high mitotic index, and this is why, like I said, when you look at the cells, you're going to see that the cells are very big in size, and as well that you can see those cross type of nuclei, the like I showed you earlier. Uh, so remember that to talk about aplasia once again, giant tumor cells that loss of polarity, all the tumor, malignant tumor usually lose polarity, and many mitotic figure happening. You don't recognize the tissue of origin, and it's completely disorganized. So, so this is why when you look at the different aspects of tumors, let's start from the benign tumors, which are well differentiated, versus toward the malignant tumors that can be well too poorly differentiated, and then you're going to have the anaplasia itself. But between them, actually, you're going to have what you call the dysplasia. Most of the dysplasia can be considered as precancerous tumors. And remember, for USMLE, you need to know the precancerous tumors, which I'm going to give you later on. Precancerous tumor, why? Because these are tumors that can be preventive. One of the example can be cervical cancer. So if a woman do pap smear very often, well, if there's any change within pap smear, you know that you can treat it because you can remove it right away. And this is why the recommendation of having pap smear at least once a year for a sexual active woman, or once every 3 years, depending on the sexual activities um, and the affection with HPV as well. But dysplasia as well can go different way, from moderate to cancer inside you, and the cells also will become bizarre type of cells. So the anaplasia, you're going to have different type of cells. This the big one will be the tumor giant cells itself, but otherwise The nuclei are very big, dark, abundant. And remember, the beginning of each of these cells are going to be because of mutation. So some mutation will give you well-differentiated type of tumor. Some mutation will give you poorly differentiated type of tumor. More mutation you're going to have, bad it is, more risk you're going to have overall. So here, typical cancer with mitotic figures. Here, mitotic figure, nuclei very dark. The cells start to divide in here. In comparison to a normal cells nuclei. So always compare your nuclei to a normal cells to determine if there is a problem or not. Look in here as well, dark division. And here you have a necrosis that is happening, which is normal in case of tumors. So you have this cell's loss is dead, lost nuclei. And remember to know necrosis, it's a cell that do not have any nucleus unless it's a red cells or a platelets, which we don't call cells actually. Here as well, see division of the cells. You lose connectivity between the cells themselves. Here as well, you see here there's multiple cells that the division happening. The cell become abnormal. This is most anaplastic. This is another anaplasia, but in this anaplasia is not the usual that I showed you so far. But what you notice is the nuclei are very, very dark. You lose the connection. You see the cells lose the connections and the adhesion between each other. So it created a kind of ulceration within this bladder. So plus you have a lot of blood vessels. That is typical tumors. Yeah, as well. See the cell are big. The cell are bizarre. The nuclei are very, very dark in color, and even the structure of the epithelium is different. They start to be bizarre, change, and here you have the cells that start to detach itself, and you have some hemorrhage going on, and here you see all the many blood vessels that are going on in here. So this is transitional type of carcinomas. Uh, if you look at the dysplasia in this picture, so the normal tissue, and then when you have dysplasia already, you start to see that almost the tissue look like that it collapsed, and the cellularity start to decrease. The cells start to become a bit darker. Moderate dysplasia as well. See, you don't recognize the same architecture as the normal one. The cells start to collapse completely, become darker. The nuclei become bigger in size. And then a severe dysplasia, as you can call it cancer in situ. And what you want to have, big nuclei this time. It didn't go above the basal membrane, so it's okay. Well, it's not okay, but usually when you see this is where you start to have, uh, for example, if it's a cervix, you start to burn or you start to remove the area that start to have these type of changes. Remember that metaplasias usually are risky as well as cancer because it's going to happen like this. And remember, by definition, a metaplasia is a tissue that is going to change to another tissue with a totally different function. And you're going to have metaplasia most of the time when you have aggression, when you have multiple trauma, inflammation. And could you give me one example of metaplasia? Yes, Barrett esophagus. Very good. Which is the most common one. So everywhere that you have squamous stop GRD, yes, that can give you, but the GRD is the cause of the Barrett esophagus. Um, and how you recognize it by on histopathology. What is the criteria? What is the characteristic of the tissue change? Yes, goblet cells, exactly. Because this is a change to intestinal type of epithelium. So you're going to find a lot of goblet cells. Now, it's a change from squamous tissue to a columnar tissue with a lot of goblet cells. And this is how you recognize it. Did you get it? Squamous to columnar. And columnar for GI do have a lot of goblet cells. Okay, so this is an example of a normal so remember, usually if you have hyperplasia, which is an increase of number of cells, like in here, usually hyperplasia is caused by a change in function, increase of the function of that specific organ. Sometimes this hyperplasia can become abnormal and become dysplastic or dysplasia, and sometimes, well, it go back to its original position. For example, uh, a pregnancy, endometrium goes towards the hyperplasia, so you're going to have more muscle, more of the tissues. But after pregnancy, everything goes back to normal. Doesn't goes to dysplasia. But in some situations, for example, um, when you have oestrogenic impregnation, then hyperplasia will happen, and then from there, cancer happen. And that is a typical for breast cancer. And then you're going to start to see, if you have hyperplasia, then in dysplasia, you're going to start to see the cell starting to change. Some becoming bigger, bigger nuclei. It's mostly nuclei that they become bigger. The cell become bigger, and then you're going to have different type of cells. And more it goes, and more you're going to have a change in the nuclei that become darker and darker until become a cancer. So this is why in here I put you these different type of changes. Remember that one good thing, and remember that for a question, that dysplasia usually are reversible, meaning that if you stop the aggression, for example, if you stop estrogen, you are going to have a regression of the dysplasia. Everything goes back to normal. Uh, if not, then you're going to have cancer inside you. So this is why the nuclei are going to increase in size, increase the ratio between nucleus and cytoplasm. Chromatin is going to increase because it become a bit darker, bigger, and it start to be clumping. And every time you hear the term chromatic clumping, think about cancer and to prove otherwise. The nuclear membrane itself is going to change, and that is typical for cancer. And then everything becomes thicker. The membrane becomes thicker, and the cell become abnormal. In the cytoplasm itself, you're going to have a differentiation. For example, if it's a keratin differentiation, you're going to have an increase or decrease of the keratin by itself. Other than that, keep in mind that hyperplasia can be a risky factor to become dysplasia. So in here, it's just resuming what I was saying. So in normal cells, you have normal nuclear ratio between cytoplasm is good, is big. And then when you start to have a dysplasia, the nuclei start to change, start to become bigger. And what you notice is more you go to the severity, and more the cytoplasm ratio start to decrease. So here you're going to have all the, like I showed you in the previous picture as well, all the nuclei become bigger, bigger, and then uh, after a certain portion, the nuclei become very dense, very dark, and they start to divide. And once this division started, so then you talk about cancer in situ, and then if it goes above the basal membrane, then you talk about the invasion itself. It's the cancer per se. And this is why classification within cancer are very important. And if it's and the grading is very important. And if it's 1 and 2 grading, that is good. If it's 3 and 4, that is bad. Here as well, showing you this is a dysplasia. This is going on. You see that the nuclei become very dark, darker and darker if you compare them to the other. Here as well, darker. Here the normal. Here abnormality. And so you, in this situation, this is a moderate to severe dysplasia that's going on. So this one, you can think that it goes to cancer in situ. So you can start to burn it. Same deal here, where you have the nuclei becoming bigger, and the ratio between cytoplasm starting here. See, the ratio cytoplasm nuclei are very small. You have more chromatin than cytoplasm. So remember, the keyword does not go beyond the basement membrane. That is the big definition. They can ask you this definition, simple as that. So this is why I put it very big. And I know that many students still, when I was given exam, was given this type of question. I still didn't know the difference. And this is what you call a stage 0 because there's no invasion yet. Staging is when the invasion is going to start, or you can call it a pre-invasive dysplasia. But when you have this type of cancer in situ, this is what you start to talk about. For example, another example of cancer in situ, the ductal carcinoma in situ, which do not go beyond basal membrane. But this type of carcinoma of the breast usually invade the lumen more than anything else. The squamous intraepithelial lesion, remember the term SIL, which is when you look the epidermis itself or the cervix itself, these are the changes or the dysplasia themselves that become cancer in situ. So you're going to have a two type, the low grade or high grade. If it's a low grade, usually it can go to high grades. Third progression. If it's high grade, usually it goes to malignancy. So remember these two classifications, so why I put them in red. The ductal carcinoma in situ, you're going to talk about it when you do the OBGYN or breast cancer. So here you have in situ, didn't go to beyond basal membrane, and here it goes to beyond basal membrane. So same deal, different way to look at it. More you cut it differently, more you might make sense. So this is a typical CIS. We see the nuclei that become a bit bigger, that start to change. You see here salt and pepper type of looking nuclei, and it start to become darker, and nuclei are happening, and here the nuclei are very dark. So this is mostly cancer in situ. Here, same deal in here, so it's a CIS as well. Nuclei start to change completely. So now, like I said earlier, you need to know what are the precancerous cells. Why is because if you have pregnancy, it's about what is next step in your management. What do you do next? And actually, prevention can lead to the ablation of this type of tumors. So anything that hyperplasia, like I was explaining, so some hyperplasia goes back to normal because they are physiological, but some are abnormal, and that will give you, for example, endometrial hyperplasia. If you have osteogenic impregnation, it can give you endometrial carcinomas. And this is, like I said, one of the most common cancer in elderly after a postmenopausal woman. So if an 80 years old female, remember, comes with, I had menses yesterday, I'm really happy, then think about endometrial cancer. Breast, any hyperplasia to the breast, lobar or ductal, can lead you to lobar or ductal carcinoma in situ. That can be invasive as well. Remember cirrhosis, this one is easy. That can give you hepatomas or hepatocellular carcinomas. And any causes that give you cirrhosis, like hepatitis, like alcohol, like drugs, all these can lead to exactly the cirrhosis itself. So that is obvious. So the dysplasia, the most important dysplasia that can become cancerous are around the cervix, skin, bladder, and bronchial epithelium. Especially the bladder. Bladder, you're going to have many causes, and one of them can be the dye, or it can be schistosomias, which is this parasite that invade the bladder that you see in some area in Africa or South America that can be destructive. Type cancer, skin cancer. Obviously, it depends. It can be radiation, it can be the sun, but skin cancer is not only squamous cell carcinoma, but it can be also melanomas. Metaplasia. Every metaplasia is a risk, and the one that you know already is the Barrett esophagus. And the Barrett esophagus that can give you adenocarcinoma esophagus. This is why it's something like 10% of the patient that you have Barrett esophagus that can have this type of cancer. This is why you need to follow them closely by doing an endoscopy at least once a year, and then decide if you want to do it often or you want to just do an ablation, thermal ablation of the lesions. So the any inflammatory lesion, especially ulcerative colitis, but also Crohn's disease as well. But we talk more about ulcerative colitis because the risk is higher. They are higher than Crohn's disease. But Crohn's disease, as the ulcerative colitis, can give you carcinoma of the Crohn. Anything that is atrophic gastritis. Remember, the atrophic gastritis can end up with a macro vitamin B12 deficiency, anemias. Keep that in mind because you don't have the influencing factor. Uh, the Hashimoto can give you lymphomas. Need to be careful. Anyone that has Hashimoto need to be followed for a lymphoma. Uh, the polyposis, usually chronic adenoma or polyposis, are always a risk. There's familial and non-familial, which we're going to talk about later on. But are many of them are risk of coronary cancer. Any polyp that is bleeding, actually, you need to remove it as because there's a risk of it. Non-fibroma as well can have malignancy of the schwannoma. Usually, schwannoma are benign, but in this situation, it can become malignant. So know all these precancerous lesions. So this is an example of the bone disease, which is a squamous cell carcinoma in situ in the penis. And usually doesn't do much, and it doesn't grow as well very deep. But the treatment usually is early, is on here. Here is this carcinoma in situ of the vulva, and you see there's a lot of changes within this vulva, and that is the problem. This is the dermalotypical squamous cells. But for UCMLE, this is not for step one. Maybe for step two, yeah, but step one, just remember that it's just localized. So most of the invasion are malignant, not much of benign. Benign, like I said, it push the tissue. It doesn't have the capacity of malignancy unless it becomes fibrous. So here, different ways to. So the benign, you're going to have a capsule around. You're going to have it's round, it's regular, it's symmetrical, it's pushing the tissue. So the effect of this is one thing that is important is the mass effect that the benign tumor do have by pushing the tissue away, and you might see that as well within the brain when you have benign tumor of the brains. Or malignancy can have one big tumor, but what you notice, invasion, local, regional invasion. So this hepatoma start to invade, and remember this liver, it's not much of cirrhotic, so it just happened. It can be just hepatitis. The difference between the primary, see the primary, you have a very big one, and then you have small tumors around it, because when they spread, they have the time to grow, a different timing. And this is why when it's metastasis, they are different sizes, but many of them. So you have big one, small one, very small one. exactly as we talked about this morning on the X-rays. If you remember, when you look at multiple lesions within the lungs, that goes from the base to the apex at different sizes. Um, that is the malignancy. So these are the the introduction of the tumors. Tomorrow we're going to do the clinical presentation of the tumors, which are very important to understand before we start to do the benign tumor per se and the malignant tumor per se. And the malignant tumor, once again, there's a lot of molecular biology that we need to go over as how the tumor form, etc., etc. Any question? Actually, for you can tomorrow night you can we tomorrow night we can do tumors from 6 to 8, and so start to read about clinical presentation of the tumors, and then start to read about the tumor markers. Review a little bit the tumor markers and review histology. And don't forget review histology. Review histology. Uh, Gia, I'm going to go over your farm thing, and then get back to you. And then didn't forget you about what we talked about. Uh, I didn't have time to do it, but I will do it for sure. Okay. Uh, since I'm preparing for the live opening, which will be around May, and I'm going to give lecture in university here. So that is took me some of my time, but I will send you everything. And Kayla, I will send you as well an exam. Try to do it to see where you are, and we go from there. Okay. So talk to you tomorrow night, and hopefully Tony will join us. She had problems, but okay. You too. Bye. Talk to you tomorrow. Study, 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 study. Do as much as question as you can.